Hey guys, it's Professor Rich, and we're going to start going through respiratory disorders. So throughout this PowerPoint, we are going to discuss the assessment of respiratory function, oxygen therapy management, infectious respiratory disorders, upper airway disorders, and lower airway disorders. So assessment of respiratory function. The major functions of the respiratory system are to perform ventilation and respiration. Ventilation occurs as air moves into and out of the respiratory system through the process of inspiration and exhalation. During ventilation, the structures of the respiratory system filter and humidify the air entering the system. The process of respiration occurs as oxygen and carbon dioxide are exchanged at the level of the alveoli. After respiration occurs, the circulatory system is responsible for transporting the oxygenated blood to the tissues of the body. This movement of oxygenated blood into the tissues is known as perfusion. The circulatory system provides the body with oxygenated blood and then returns the deoxygenated blood back to the lungs to allow for reoxygenation through the process of respiration. In addition to the processes of respiration and ventilation, the respiratory system is responsible also for acid-base balance, the exchange of carbon dioxide for oxygen in the lungs, and the renal secretion of bicarbonate maintain the body's pH between 7.35 and 7.45. It's for speech. The movement of air through the vocal cords allows for vocalization of words. Sense of smell. The movement of air through the nose allows an individual to smell odors in the environment. Fluid balance. Water is excreted as vapor through the exhalation process, and this helps maintain the body's fluid balance. So for inspiration, in order for ventilation to occur, there has to be movement of the diaphragm. The diaphragm resides below the lungs in the thoracic cavity. Inspiration occurs when there is stimulation of the phrenic nerve. The phrenic nerve is responsible for the movement and contraction of the diaphragm. Contraction causes the diaphragm to lower, compressing the abdominal contents and pulling the parietal pleura down to allow for the expansion of that chest cavity. The expansion of the chest cavity increases in volume and capacity of the lungs and decreases the pressure within the lungs below the atmospheric pressure. The decrease in pressure of the lungs below that atmospheric pressure causes air to rush in because air moves from areas of high pressure to low pressure. Then we have expiration. So this is a passive process that occurs as the diaphragm relaxes. So that diaphragm relaxes and pressure is exerted on the lungs by the chest and abdominal cavity. The decrease in size of that thoracic cavity causes an increase of pressure within the lungs that exceeds the atmospheric pressure, causing the air to passively leave the lungs through expiration. So history of present illness. So this is an important component of the assessment process. Information that should be obtained during the HPI are factors that exacerbate or improve symptoms, pain, cough, change in weight, shortness of breath. So factors that exacerbate or improve symptoms should be assessed to determine if the cause or degree of the illness. Factors are like walking, climbing stairs, rest. This can all indicate a level of the respiratory system and cardiac system. So if symptoms do not improve at rest, it may indicate a greater degree of dysfunction than a patient whose symptoms are only present with activity but improve with rest. Pain. So for pain assessments, they should include the quality, location, radiation, severity, and precipitating factors. If they're reporting pain in their thorax, they could have a cardiac issue, GI issue, or respiratory issue. Patients with a respiratory disease process may not experience any symptoms of pain because of lack of sensory nerves in the lungs and visceral pleura. They could also have pleuritic pain as well, which could be from an inflamed parietal pleura called pleurisy, and that's usually rubbing, sharp, or a stabbing pain, and it occurs during ventilation. Patients could have a cough, change in weight, shortness of breath. We should ask their current medications. What are they prescribed? Different allergies, past medical history, any previous surgery or family history, occupational or area of residence, Smoking history, absolutely. Social history, and then their travel history as well. In addition to obtaining their history, we also need to do our physical assessment. So inspection is the first step in the assessment of the respiratory system. Abnormalities in the patient's level of consciousness, orientation, that can indicate hypoxia. During inspection, we should assess the patient's speech. The patient should be able to speak freely and full and complete sentences. If they have respiratory distress, they may not be able to do that. We want to look at their fingernails. Do they have any clubbing? This could indicate chronic respiratory dysfunction. It could be chronic hypoxia, commonly seen in patients with COPD. The nose should be inspected. Look for symmetry and size. Check for discharge, bleeding, masses, swelling. Look at the color. Are they pale? Are they cyanotic? And then we should inspect the mouth. Look for open sores, bleeding, masses. Note the color, any consistency. Is that mucosa pink and moist, or is it dry, cracked? Is it sticky mucus? That could indicate dehydration. And if they're pale or cyanotic, that could also indicate like tissue hypoxia. Inspect the neck. Look for symmetry, color discoloration, masses, cyanosis, swelling. The position of the trachea, is it midline? And then look at the thorax. So look at the skin integrity. Look for scars, masses, lesions, discoloration. Check for retractions on inspiration. Retractions occur when the muscles pull inward during inspiration, and that can cause the skin to pull around the ribs. This is what we really look at when we look at pediatrics and they're having trouble breathing. It means that they're having an increased work of breathing and respiratory distress. Check for chest symmetry on inspiration. Compare the thorax on the left side and the right side, as well as anterior to posterior. Normally, the AP diameter, when compared to the lateral diameter, should be 1 to 2. Whereas a patient with like COPD, they're going to have a ratio of 1 to 1, and that means that they're barrel-chested. Also look at the spine. And we're going to look at vital signs. So specifically for respiratory, we're going to look at their respiratory pattern, the rate, the depth, effort. The patient shouldn't be aware that we're checking respiratory when we are, because if they know that they're being observed, sometimes they could start thinking about it too much and breathing differently. We would like a rate from 12 to 20. If it's greater than 20, they're tachypnic. If they're less than 20, then they're britty. So if they have no respirations, that's called apnea. When the respiration rate is obtained, look for those retractions, any nasal flaring, any use of accessory muscles, we call it belly breathing. And then also look at their pulse oximetry. Palpation. So the nurse should lightly palpate the trachea, and this is ensuring that it's midline, it's non-tender. We could palpate the anterior and posterior thorax, look for pain, crepitus, masses, deformities. Crepitus occurs when air is trapped under the skin, and it's best described as like a crackling feeling. And this could be caused by a pneumothorax or trauma to the chest. When you're palpating the thorax, assess for equal expansion of the lungs by placing your hands on both sides, as well as anterior and posterior. Percussion. So assessment of percussion between the ribs should be performed following palpation. Normal percussion sounds over lung tissue is like resonance. So look on tables 23.1 and 23.2, and you'll see more information on percussion. And then auscultation. So using the diaphragm of your stethoscope, we're going to listen to the patient's lungs. We want to listen to right and left, paying careful attention to ensure that the patient's not becoming dizzy, lightheaded during the assessment, have them take deep breaths. Normal lung sounds can be divided into 3 types: bronchial, bronchovesicular, and vesicular. We also have normal lung sounds, and then we also have abnormal or adventitious lung sounds, which are like our crackles, wheezes, rhonchis, and pleural friction rubs. So please open your book to page 449, your F.A. Davis book, and you're going to get more information on your lung sounds, okay? And I also want you guys to pay attention to these as well, because we do need to be familiar with these locations. Respiratory diagnostics. There are several tests here. So we have our ABGs. So this is looking at our pH of our blood, our PaCO2, our bicarbonate, which is our HCO3, and our PaO2. We don't go too crazy into ABGs right now. We'll have another slide on them. So we'll talk about it then. Pulse ox. So we would generally like it between 95 to 99%. This is the saturation of hemoglobin with oxygen. With the patient with COPD, we'd expect it more like 88 to 92, and we'll talk more about that later. Capnography. This is looking at our PaCO2 monitoring. This is continuous. We see it on our monitor. It's great. Sputum analysis to check for microorganisms, any abnormal cell growth. Chest x-rays. This is looking at the lungs, heart, pleural space. PFTs. So this is looking at our lung volume and lung functioning. So the patient's asked to inspire and exhale into a mouthpiece, and during the test, the patient's given instructions to alter his or her breathing patterns, allowing for different tests to be obtained. So this is a great test to see how our lungs are functioning. Then we have a bronchoscopy, and this is when a scope goes down and it allows for visualization of the respiratory tract. We can analyze tissue specimens. We could perform a biopsy. Thoracentesis, so this is when a needle goes into that pleural space and we're looking at a specimen, fluid, or air, as well as a lung biopsy, and this is when we are removing tissue for analysis. This is typically how our lung cancers are diagnosed. So looking at our ABGs, we're not going to go too crazy with this right now. What I want you to pay special attention to is our PaCO2, which is a measurement of carbon dioxide in the blood. So the normal range is 35 to 45. And then we're also going to be looking at our PaO2, which is a measurement of oxygen in the blood, and we like that 80 to 100. If it's less than 80, we're looking at hypoxemia, so the patient's not getting enough oxygen. Then we have our SaO2, and this is the percentage of hemoglobin that is bound to oxygen, and this should be our 95 to 100%. This is when we're looking at our saturations as well. So again, with our COPD patient, we're expecting that to be low, and 88% is kind of the lowest we prefer it. We don't really want it going any lower than that. So that's kind of where I want you to keep your focus with the ABGs for now, and then when we get into fluid and electrolytes, we're going to dive way deeper. All right, waveforms. So when we have a patient on pulse oximetry, we need to look at their waveform. So if you're getting a waveform or a pulse ox reading of like 70%, but your waveform looks like this one, it's not a good waveform. This one's not good. We don't count this. We don't count this. We want this perfect waveform, and we call this like a nice plaque. So this is what we want to see. And then when you see your 95%, we are happy because we have a beautiful waveform, and this is what it looks like, okay? All right, so oxygen delivery method. So there's several ways to deliver oxygen. There is the least invasive, which is your nasal cannula, all the way up to our mechanical ETT tube ventilation. So for nasal cannula, this is great for your patient that is, 80% COPD patient. Let's start them on 2 liters nasal cannula and see how they do. And we can titrate it up to 6 liters. And we have our simple face mask, which is for 6 to 10 liters of oxygen. Non-rebreather, which is up to 15. In the hospitals, you'll mainly see your nasal cannula to your non-rebreather. And then you'll also see your BiPAPs and your CPAPs, as well as your high flows. We're not going to go too crazy with them. We're going to talk a little bit more about CPAP. So for your CPAP, this is positive pressure. It's usually continuous. It's commonly used with patients with obstructive sleep apnea. Helps keep the airway and trachea open during sleep because of that continuous pressure. So it delivers a set of positive airway pressure throughout each cycle of inhalation and exhalation. It holds open those upper airways. Patients with atelectasis or collapsed alveoli can benefit from this, especially after surgery. And it's also used for any obstructive airway patients. This slide just looks at the CPAP machine and mask that is commonly used. And as you can see on there, how it kind of keeps that patient's airway open. And again, we'll talk a little bit more about this when we talk about obstructive sleep apnea. So your invasive oxygen delivery. So this is when we're looking at our vents. And again, we just briefly touch on this as well. So it delivers 100% of oxygen. It's warmed and humidified. It provides it delivers oxygen to lungs under pressure throughout inspiration, helps keep those alveoli open. It prevents alveoli collapse during expiration, improves gas exchange. It decreases the patient's work of breathing. There's several different settings for the vent. It's placed by a CRNA, physician, pulmonologist, NP, depending where you live and work. RT can even place it, as well as paramedics can place it in the field. And then its endotracheal tube is usually how it's initiated, and then also you'll see your patients with tracheostomies and vents. For these patients, this is critical care, or they'll go to a long-term acute care. To decrease the risk of ventilator-associated pneumonia, oral care must be done every 2 to 4 hours. This is something we can delegate to our UAPs. Tracheostomies, they could be permanent or temporary, and they bypass the obstructive upper airway. They're common in patients with MS, cancer, facial surgeries, and so for patients with trachs, they're going to need like a passing mirror valve to talk because it passes through the trach tube, which isn't the vocal cords, but it can still be difficult for them to speak after having it placed. So oxygen therapy doesn't come without complications, especially for our COPD patients. So our COPD patients are put at risk for oxygen toxicity. So if you have a COPD patient and they're satting, 85%, and you put a non-rebreather on them at 15 liters per minute, you're putting at very high risk for this oxygen toxicity. So these patients, they could manifest with a non-productive cough, dyspnea, crackles, hypoxemia, atelectasis, pulmonary edema, substernal chest pain, GI upset, and then it goes all the way to like they can become lethargic, difficult to arouse, and it can get pretty bad. So intervention, so obviously prevention's priority. So we use the lowest level of oxygen that we can to treat the condition. We're going to monitor their ABGs, notify the doctor if their PaO2 is greater than 90. And then we also have O2-induced hypoventilation, which is when the PaCO2 increases gradually over time and it becomes like 60 to 65, the CO2 receptors no longer function and they don't stimulate breathing. So again, same idea, we're going to use the lowest level of oxygen that we can. And then hypoventilation, it usually occurs within the first 30 minutes of the oxygen therapy. So our changes in older adults. So they have a decreased surface area, they have a decreased lung capacity, more dead space within their lungs, decreased vital capacity. So they can expel, I'm trying to think how to word this, they expel a lot less air than what we do. They don't have the same capacity that we have. Their cilia can be ineffective at removing dust and irritants, which can make them get sick easier because they have a decreased cough reflex, so their body's mechanisms don't work as well to prevent infection. Kyphosis, that humpback, so that can result in vertebral collapse and impairment of the respiratory system. And then they get more tired when they're breathing. So a patient that's older that has an increased work of breathing is going to tire out a lot faster than someone younger. Infectious respiratory disorders. So in order for a respiratory infection to fully establish within the lower respiratory tract, the following barriers must be avoided and these conditions must be met. So first off, avoidance of trapping in the mucociliary layer of the upper respiratory tract. So the cilia don't trap the infection, and it is able to go down lower. Avoidance of the phagocytic action of alveolar macrophages in the lower respiratory tract. Infectious organisms must be airborne. Particles must be less than 5 UM that remain suspended in the air for a prolonged period of time and have the ability to remain virulent or toxic while in the air. And 4, there must be sufficient numbers of infectious organisms inhaled and deposited into the susceptible tissues with both the upper and lower respiratory tracts, preventing the innate protective mechanisms from functioning effectively. So our body has a lot of ways to try to fight off these lower infections. However, they happen. We'll have an inflammatory response of the respiratory tract. So that pathogen comes in, establishes itself, and our body initiates an inflammatory response. So by direct stimulation of the infecting organism, it leads to the secretion of pro-inflammatory cytokines, and neutrophils are recruited to the infected alveoli along with other immune cells and serum components, and that's going back to chapter 18. And then we have capillary permeability, which increases in the alveoli-filled fluid from the plasma proteins. And then that accumulation of fluid or exudate assists with the movement to nearby alveoli, and the fluid and exudate-filled alveoli are preventing from effective gas exchange at the alveolar capillary level. So this produces various degrees of hypoxemia, depending on the severity of the infection. So moving right along to our first infection. So influenza. I know we talked about this briefly on the past PowerPoint, but we're going to talk about it a little bit more. So first off, we know that this is spread by droplets, right? These patients, so some of them just have cold symptoms, but it's usually more severe and it's usually a quicker onset. They could also have fever, headache, sore throat, severe nasal congestion, cough, that generalized just not feeling well, muscle aches, pains, fatigue. So to diagnose this, we usually do a nasal swab to get a viral culture. There's also the rapid influenza diagnostic tests, which are the RIDTs. Treatment, so obviously we direct our treatment at prevention, the annual vaccination. However, if you have the flu, we're going to do antipyretics, so we want to help with those fevers, so we might do some Tylenol. Analgesics, maybe we'll do some NSAIDs like ibuprofen, as well as antivirals. There is Tamiflu out there. Complications, so primary influenza can lead to a influenza viral pneumonia. So these patients, as disease progresses, they have diffuse crackles. So this is an abnormal finding. So if you go into your patient's room and they have a fever and chills and body aches and they're coughing, okay, yeah, they have the flu, you already know that. But if you start hearing diffuse crackles, this is abnormal, and this means that the disease is getting worse and they might have that viral pneumonia. Nursing interventions. So we want to do vital signs, a thorough head-to-toe assessment, again with those droplet precautions, medications. We want to educate them on the flu shot, semi-Fowler's position, give them some oxygen if they need it, increase fluids, make sure that they have a nice balanced diet. If cultures and labs are ordered, get them completed. And then for the vaccine, so last week or the last, classes, we were talking about the flu vaccine not being live, but there also is a live version. So there's both, and I just want to touch on the fact the live version does have a little bit more contraindications, which is why we don't hear about it as often. So it shouldn't be given to someone immunocompromised, because if their white counts are low and they get a live vaccine, they're more likely to get sick. Someone who's pregnant, and then also people above the age of 50 or less than 2 years of age. Pneumonia. So according to the CDC, there is 3 to 4 million cases reported annually in the United States of pneumonia, and this can occur to anybody, any age, any time. Pneumonia is the inflammation of the lung parenchyma, which is the functional lung tissue, and it results from a bacterial, viral, or fungal infection. Organisms enter the respiratory tract through inhalation of those infected droplets, or it could be through aspiration. They evade the protective mechanisms of the respiratory tract and then initiate the inflammatory process that we spoke about a few minutes ago. Diagnosis is based on lab tests, imaging study. So we're going to look at that elevated white count, that leukocytosis, look at those neutrophils. We might look at the CRP, see that inflammation. We could look at ABGs. We are probably going to do a sputum culture. Imaging, we're going to get a chest x-ray, chest CAT scan. So the chest x-ray could show infiltrates, and then our CAT scan can show the consolidation. So treatment is dependent on the type of pneumonia. So viral pneumonia will be treated differently than bacterial pneumonia. Obviously, bacterial pneumonia, we're going to be giving those antibiotics. Make sure you're getting cultures prior for your blood and your sputum. For the breathing itself, we're going to give those bronchodilators to help open up those bronchioles. We're going to do oxygen if they're hypoxic. And then nursing intervention. So we're going to be doing vital signs, a thorough head-to-toe assessment, again with that sputum culture before your antibiotics. Pulmonary hygiene, elevate the head of bed, check their eye and nose, nutrition. We really want to encourage ambulation with these patients about 3 times a day. We want to increase fluids. This is going to help mobilize those secretions. We want to get them out so that they can get feeling better. We're going to teach them about the incentive spirometer, how to use it, how often. And we want to group their activities. So we should approach activities of care with intervals of rest because we don't want to overexert them and fatigue the respiratory system. Because that will decrease the tissue oxygenation, and that's already going to be limited due to the pneumonia's infectious process. Tuberculosis, commonly known as TB. This is a significant and potentially life-threatening respiratory infection, and it's caused by an organism called Mycobacterium tuberculosis. This is an aerobic acid-fast bacillus, and it infects 1/3 of the world's population. It is closely monitored by the CDC. So tuberculosis is typically transmitted by aerosolized droplets inhaled from coughing or sneezing of an infected individual. These droplets are tiny and remain suspended in the air for several hours, which is why these patients are put in negative pressure isolation rooms on airborne precautions. Tuberculosis has a few different classifications. There's latent tuberculosis, primary progressive, and drug resistant. For latent, these patients have this infection. They don't have symptoms. These people are healthy. So basically the inactive bacilli remain dormant within the healed granuloma. And again, these patients have no symptoms. They're not sick. They're not contagious. The problem with this is when the patients become immunocompromised or something happens that it makes it easy for the TB to become primary or symptomatic. So different factors are like an HIV infection, diabetes, chronic renal disease, long-term steroid use, sepsis, or malnutrition. So the TB then has the ability to become infectious and symptomatic. So symptoms are a low-grade fever, fatigue, weight loss. They can have night sweats, cough, rust-colored or like a blood-streaked sputum, so they're coughing up blood. They're short of breath. They're having trouble breathing. They can have rales. To diagnose TB, we do that PPD or that Mann-Tox test. That's the one on your forearm. And a 12 mm in duration indicates a positive test. There's also the quantiferon blood test, sputum culture, and chest x-ray. For patients that are positive and get sick with it, they do need to have repeat testing to evaluate for potential reinfection if they're susceptible. And then the treatment, so there is a 4-medication combination, and it's recommended for TB, and it goes on for 9 to 12 months. So these patients, they need to be quarantined for a minimum of 6 weeks. to prevent the spread. They might have a visiting nurse come who will have to, adhere to those airborne precautions and help with medications. And then again, in the hospital, we need to make sure they're in a negative pressure isolation room and everyone's wearing their N95s and gloves. Moving right along to our upper airway disorders. So our first airway disorder is rhinitis. So rhinitis is classified as allergic or non-allergic and acute or chronic. It's inflammation and irritation of mucous membranes lining the nose, but it can also affect the eyes, throat, and ears. Allergic rhinitis is categorized as perennial, which means that it occurs throughout the year, or seasonal. It occurs in response to exposure to allergens found in the environment, like medications, food, occupational irritants, mold, dust mites, weeds, trees, animal dander, foods like peanuts, cow milk, eggs, wheat. And then those medications are commonly like ACE inhibitors, penicillin-based medications, aspirins, and other NSAIDs. So it occurs in response to offending allergens. The lining of the nasal mucosa becomes inflamed, congested, edematous. Mechanical obstructions within the nose or sinuses, such as polyps, nasal septal deviation, and hypertrophy of the nasal turbinate or sinus tumors can also result in the development of rhinitis. So non-allergic rhinitis presents very similar to allergic rhinitis, but it doesn't involve the immune system. The common example of the non-allergic rhinitis is the common cold. Acute rhinitis usually can last from 1 to 3 weeks. However, chronic can last up to 12 weeks. Symptoms include our nasal itching, eye itching, sneezing, nasal congestion, sore throat, rhinorrhea, which is that really runny nose, so excessive nasal drainage. And then treatment, so it really depends on what the cause is. Our diagnosis, we base that on a history and symptoms, kind of seeing, which is it, are allergic versus non-allergic? Is this all year? Is this seasonal? What's it related to? So pharmacologically, we're going to be looking at our symptom relief. So oral antihistamines like Benadryl, or we could be doing the second generation ones like loratadine, also known as Claritin. Some nasal spray. I see a lot of that fluconazole, the nasal spray to help. Corticosteroids, decongestants. So we're really focusing on symptom relief for this because it's kind of self-limiting. Depending on how advanced these symptoms are, we can go into looking at their vital signs. We want to make sure that they don't have an infection, so make sure they don't have a fever. Check their heart rate and blood pressure if they're on these different medications. We want to look at their pulse oximeter, make sure that they're breathing effectively. And then we want to prevent the spread. So if it's a cold, teach them proper hand hygiene, covering their mouth and whatnot when sneezing, disposing of facial tissues, and just the basics of not spreading our germs. Rhinosinusitis. So this is also known as sinusitis. However, it's properly called, or the preferred term is rhinosinusitis. So this is symptomatic inflammation of the nasal cavity and the paranasal cavity. So it's infection, inflammation of those paranasal sinuses, and we have 4 paired air-filled spaces that surround the nasal cavity, which you can see on here. There's 1, 2, I know I'm very bad at this, 3 and 4. These are our cavities, and they're air-filled. So it's a maxillary, frontal, phemoid, and ethmoid. So inflammation of these passages causes vasodilation, which increases blood flow, causes vascular permeability, which then reduces the size of these passages. So the nasal congestion occurs because of the swelling, and then it kind of becomes trapped, which obstructs the nasal airflow. So acute rhinosinusitis is diagnosed by the presence of 3 symptoms. So they have purulent nasal discharge or drainage. So this is that green yucky mucus, nasal obstruction, facial pain, pressure, or fullness. A lot of people get those, like, I have a sinus headache. So normal nasal secretions are clear, but for this, they're going to be cloudy or green and yucky looking. Nasal obstruction, this could be reported as that congestion, stuffy nose, or they feel like their nose is blocked, they can't breathe through their nose. Facial pain, again, that's anterior face, periorbital areas. It could be that diffuse or localized headache. And onset of these symptoms really depends on the onset of the rhinosinusitis itself. Other symptoms could be fatigue, fever, maxillary or dental pain, cough, ear fullness and pressure, nasal or purulent drainage, and then indications of like extra sinus involvement are like neck stiffness, orbital protrusion. This could actually even lead to cellulitis of the face. That's a complication of it, as well as meningitis and abnormal eye movement. So as these passages or these cavities get filled up, it's going to, press on nerves and cause other issues. And if it, stays there and becomes infectious, that's when you get that facial cellulitis. So diagnosis, it's primarily on physical exam. So we're going to focus on looking at the ears, the nose, the throat, sinuses, the chest. We look for signs of inflammation, tenderness, firmness. We're going to do light palpation over the sinus and orbital cavities, light percussion. We want to check out these vital signs. Diagnostic testing could include like a CAT scan and MRI if they don't meet the diagnosis through like just clinical observation. And these radiographical studies could show like fluid or thickness in the linings of the sinuses. So the focus on treatment, it's based on the etiology. So our goals are going to include pain relief, reduction of that mucosal inflammation, and treating infection if there's one present. So we could do like normal saline irrigation. A lot of like times they do the neti pot. So the patient pours or sprays normal saline into their nostril. It flows through the nasal cavity. It pours out of the other nostril. Irrigation is beneficial because it can help remove infectious debris, bacteria, allergens, and inflammatory mediators. It also can decrease edema of the nasal mucosa and viscosity of the nasal secretions. And then, so antibiotics, so if it's bacterial based, then antibiotics are indicated. However, if it's viral, we really want to prevent giving antibiotics. So if it's left untreated, again, it can result in several complications. They're rare, but it could become orbital cellulitis. They can get an abscess, osteomyelitis or bone infection there, meningitis, sepsis, and subdural abscess. So this does need to be treated. We want to look at the patient's vital signs. Again, that physical exam, we're going to be palpating over their face, their paranasal, nasal cavities, look at their orbital areas. And the treatment, we're going to be doing reducing the mucosal inflammation, use that neti pot, antibiotics if needed, decongestions. All right, obstructive sleep apnea. So this is an upper airway obstruction. It's common during sleep and it results in intermittent breathing patterns. So it's a narrowing and it occurs in the retropalatal region or retroglossal region or the nose. So when a person goes to sleep, the body muscle tone relaxes, and that includes the muscles of the upper airway. With OSA, the normal work of breathing is unable to overcome the increased resistance in the upper airway, causing airway collapse. So the narrowing of the upper airway increases inspiratory pressure and intrathoracic pressure, and it results in a decreased minute ventilation and gas exchange. So ultimately, there's periods of apnea, and during this apnea, there's no tidal volume or movement of air in and out, so no gas exchanges occur in the alveoli, which can lead to hypoxemia, hypercapnia, acidosis, and increased sympathetic vasoconstrictive activity. So this is bad. It's common, like the risk factors are patients with atrial fibrillation, nocturnal dysrhythmias, type 2 diabetes, heart failure, pulmonary hypertension. And then other risk factors are male gender, obesity, cigarette smoking, alcohol use, ages 40 to 60, cranial, facial, or upper airway soft tissue abnormalities, and menopause. Symptoms are due to the relaxation of soft tissue in the upper airway. Again, it results in the occlusion of the airway. So symptoms are typically loud snoring, snorting, witnessed apnea, gasping during sleep, recurrent waking during sleep, choking. Often spouses will be like, hey, he's been having this very disruptive snoring, or they notice throughout the night that they're not breathing. These patients are commonly very sleepy during the day because they're not sleeping well at night because they're constantly waking up. To diagnosis, we're going to do a sleep history, so that's gathering information about their sleep patterns. We're going to do a polysomnography or a sleep study, and this is performed to diagnose it. It's conducted in an overnight sleep lab, and now it could also be done for home portable monitoring. And it's obtaining multiple biophysical measurements. So it's going to look at their electrocardiogram, their pulse ox, respiratory airflow, eye and skeletal muscle movement, and a electroencephalogram. So they're going to be looking at their brain activity as well. Treatment requires multiple interventions. So we're going to look at the CPAP here, and that's the treatment of choice. If the patient does have a CPAP and they're going to be admitted to the hospital for any reason, we like them to bring their own. We'll have it checked out by our hospital staff who does that, and we'd prefer them to use their own. We want to make sure that they're positioned in a non-supine position. They can use some pillows behind their back to help kind of prop them up a little bit to help keep that airway open. We want them to avoid sedatives before bed. Oral appliances are great. They have custom-made ones so that it can help maintain that airway. And then we also want them to consider weight loss because weight is a big part of this. So weight management is a huge part of it. Then there's also surgical procedures. This is not the most common intervention. It's usually secondary, and it's when patients are intolerant of the CPAP and oral appliances. So this could be getting a tonsillectomy or adonectomy, but we're not going to go too much down to this. There's also bariatric surgeries to help with weight reduction. So for these patients, we want to be checking their vital signs. If they have their CPAP, we need to call whatever our hospital policy is to have it checked to make sure it's working properly. Assess for edema, make sure that these patients are sleeping well throughout the night, administer medications as ordered. They might have hypertension, so we want to get that treated. If they have cardiac dysrhythmias, we want to be watching that closely and make sure that they're getting their medications. We want to, let's see, so we want to make sure that they know about weight loss and help them get there. We need them to help improve their sleep patterns because fewer nighttime awakenings are better. Then they'll have less daytime sleepiness and fatigue, as well as improved mental alertness, less irritability. Again, with the hypertension, make sure that their blood pressure is controlled. Laryngitis. So laryngitis is caused by upper respiratory infections, environmental pollutants, gastroesophageal reflux disease or GERD, asthma inhalers, vocal misuse or strain. So this is, periods of prolonged talking. So they say teachers, lawyers, or someone who screams a lot or talks loudly, or if you have a crazy weekend and you've been, yelling all weekend having fun, you could lose your voice after. Endotracheal intubation can cause this as well, and throat and lung cancers as well. So basically, this is a hoarse voice or someone lost their voice. And treatment, so it's really focusing on voice rest, increase oral fluids, antibiotics if it's bacterial related. So that would be that this is secondary to a bacterial infection. Using air humidifier. I know some people will use like a decaffeinated tea and honey as well to fix this, but it's mainly focused on resting the voice. Laryngeal cancer. So risk factors are tobacco and alcohol use, poor dietary habits, compromised immune system, genetic syndromes, occupational hazards, gender, age, and race, as well as GERD. So higher risk for or laryngeal cancer patients, you're at higher risk to get it if you have GERD or you're smoking. So these patients will come in, they have a hoarse voice or a recent change in voice that's not resolving. This could be a lower than usual pitch, raspy. Other symptoms are persistent sore throat, a constant cough, pain with swallowing, ear pain that doesn't go away, difficulty swallowing, trouble breathing, lump or mass in the neck, and weight loss because you're not eating well. So to diagnosis, we're going to do a thorough health history, a physical assessment. We're going to get probably an endoscopy. They might do a barium swallow. Definitely going to get a chest x-ray to rule out any other type of cancer as well, a CAT scan, MRI, and PET scan. Treatment, so radiation therapy, surgery. So for surgery, they might get a laryngectomy. This could be partial, total. If they do have this, big thing is having suction set up at the bedside, just because they can have increased secretions, blood there, and they're going to need some help getting that out so it doesn't go down into their lungs. And then there's also chemotherapy. So the big thing for these patients or patients at risk for this is teaching them about quitting to smoke because it decreases their risk for disease as well as disease progression. Laryngeal trauma. I'm just going to touch on this. This is more semester 9, but so basically this is rare. It's usually related to like a blunt trauma or a penetrating injury like an assault, so your stab wounds, your gunshots, crush injury during a motor vehicle crash, strangulation, and it could also be from prolonged endotracheal intubation, which is why we don't want our patients intubated too long. So how it manifests depends on how severe the injury is. So they're going to have a hoarse voice, pain, they could have stridor and dyspnea, trouble swallowing, they could be coughing up blood. If it swells, they're going to have an airway obstruction, and they can have hematoma there, which could also, cause that airway obstruction. Diagnosis, you could see this patient, he has a clear trauma to his neck, so physical inspection. We're also going to get a cervical CAT scan. They might do like a fiber optic laryngoscopy or a flexible bronchoscopy. So for treatment, obviously maintain that patent airway. That is always our priority. We're going to stabilize that C-spine, and they're probably going to go to surgery. Lower airway disorders. All lower airway disorders negatively impact oxygenation, ventilation, and gas exchange. Lower airway disorders can be chronic and progressive, such as asthma, COPD, and cystic fibrosis, and they require meticulous management and lifestyle adjustments to achieve maximum wellness. Other airway disorders like lung cancer can be acute with a low 5-year survival rate, and then all patients with lower airway disorders require thoughtful nursing care, support, and education to best manage their disease. Asthma. So risk factors for asthma, well, first off, what is asthma? So this condition affects the bronchial airways and not the alveoli. There's an airway obstruction and bronchial hyperresponsiveness, meaning that bronchospasms or contractions of the small airways and underlying inflammation are easily triggered by exposure to inhaled irritants. So the risk factors are obviously family history, cigarette smoking, mold, different allergens, also so like pollen, dust, animal dander, as well as air pollutants, occupational irritants, viral infections, nasal polyps, allergic rhinitis, food and drug allergies, and emotional distress. So basically these patients have exposure to a trigger that causes an inflammatory response. The immune response causes a release of inflammatory mediators, which then cause vasodilation and increased capillary permeability. Edema of the airway occurs, and then there's an increased production of mucus. The mucus causes a thickening of airways with bronchial hyperresponsiveness. Then there's a release of histamine, which also causes constriction and spasm of the smooth muscle, causing bronchospasms. So bronchospasm plus mucus production plus edema produce airway obstruction. So clinically, these patients, after an exposure to a trigger, they can have wheezing, specifically expiratory, dyspnea, coughing, increased sputum production, increased respiratory rate. They might have chest tightness, tachycardia. They could have this hypoxia or hypoxemia, which is going to make them agitated. They're going to be tachycardic, tachypnic. They could have anxiety. They could become lethargic. Patients who are having an asthma attack are likely to not be able to speak full sentences. So we need to treat this. So we're going to put them in a high Fowler's position and listen to their lungs right away. You're going to get your pulse ox. If their oxygen's low, slap on some O2s. If they're having an emergency asthma attack, we're going to give them the bronchodilator, that beta-2 adrenergic agonist. That's our rescue inhaler. For daily maintenance, they're probably going to use an inhaled corticosteroid, and this is on a daily scheduled routine, so they might take it every morning before breakfast. So complications. So asthma in an attack can lead to status asthmaticus. This can be very severe. This is life-threatening if it's not treated. We want to treat it early. So this is when an asthma attack's not responsive to treatment. So, we're giving them bronchodilators and they're still having persistent wheezing. They're starting to have accessory muscle use. So we see them belly breathing. This is bad because it can it can go to respiratory fatigue, which then leads to respiratory failure. So if our patient's not responding to the treatment, we need to, fix this right away. So patient education, so we want them to have an allergen-free environment, so as much as they can. So they should avoid dust, avoid like house plants and stuff that can increase allergies. They should avoid crowds, and they should consider wearing a medical alert bracelet saying that they have asthma, so if an emergency happens, medical authorities know. Pace activities, so this is, planning your activities so that you're not doing a million things at once and overexerting your respiratory system. Whatever medications they're on, we need to teach them medication and side effects. So if we're giving a patient a inhaled corticosteroid and also a bronchodilator, they need to understand that the inhaled corticosteroid is for like a daily scheduled use, and then their bronchodilator is that rescue inhaler for the, the emergency, so to say. They also might take anticholinergics and, again, oxygen if needed during a emergent response. They don't typically need oxygen on a daily basis. COPD, so chronic obstructive pulmonary disease. So on the left here, I have some lungs, and it, kind of shows you COPD lungs versus healthy lungs, and you can see a few differences there. So pathophysiology, airflow is limited and it's progressive and not fully reversible. This is projected to be the third leading cause of death, it probably is by now because it was by 2020. So cigarette smoking is the primary cause. However, other causes are occupational dust and chemicals, outdoor air pollutions, and secondhand smoke. So there's two conditions. There's emphysema and chronic bronchitis. Most patients have a combination of both. So emphysema is destruction of the alveoli, and chronic bronchitis is the presence of cough, sputum production for at least 3 months in each of 2 consecutive years. That chronic bronchitis is caused by exposure to inhaled pollutants. The bronchi and bronchioles are inflamed. Due to the inflammatory response, the bronchial wall thickens, causing obstruction, and then there's an increased production of that mucus causing obstruction. So these patients, as disease gets worse, they're going to have an increased work of breathing, shortness of breath. You'll see accessory muscle use with them. You might see them in a tripod position, which is kind of when they're sitting at the bed, bending, or sitting at the edge of the bed, leaning forward. They might have a barrel chest, which I spoke about briefly earlier. So their diameter of their chest might be 2 to 2 rather than 1 to 2. And again, they could have increased sputum production, cough, pursed-lipped breathing, which is kind of like breathing through a straw. I'll talk about it shortly. Skin color changes, so they might have like a red, they say like red or blue, which is the cyanotic. They're likely to have anxiety. Their SpO2 is usually less than 90, crackles, wheezes. Diagnosis is on patient history, physical assessment, spirometry. We're going to do a chest x-ray to rule out any other causes. So the two tests for spirometry are the forced vital capacity, which is FVC, and this is the maximum volume of air exhaled during forced expiration. And then they also have the forced expiratory volume in 1 second, which is FEV1. This is more commonly used, and this is the volume of air exhaled in the first second of a maximum expiration after a maximal inspiration. So treatment of COPD, there's 4 goals for it. So you want to assess and monitor the disease, reduce risk factors, manage stable COPD, and then manage exacerbations. So the assessment, this is regular pulmonary function tests and chest x-rays, especially with exacerbation. We want to give bronchodilators. They're used individually and in combination or as needed to control symptoms. Inhaled medications are introduced in a stepwise approach. So as the disease worsens, long-term bronchodilators are added. We might do inhaled glucocorticoids. Those are added when the patient's experiencing like frequent exacerbations. So the inhaled bronchodilators and also oral glucocorticoids are used at managing the breathing symptoms. If they're having an exacerbation from an infectious trigger, like a bacterial issue, like let's say pneumonia, we're going to give antibiotics. We'll use non-invasive positive pressure ventilation. So we might use BiPAP if we need for these patients to avoid endotracheal intubation. We don't like intubating these patients because they are difficult to wean off the ventilator. So we try to avoid intubation as much as we can. So these patients often get BiPAP. Complications, so obviously, like I just said, they're difficult to wean off the vent, so we avoid that. Secondary spontaneous pneumothorax can happen with these patients. They're at risk for pulmonary hypertension, which can lead to right-sided heart failure. And then they're also going to have increased airway resistance. So COPD management from the nursing angle. So we obviously are going to administer the medications as ordered. So bronchodilators, those helps the bronchial smooth muscle relax and help open the airway. Provide these patients with oxygen. So we like their oxygen to increase to 90%. We can place them on continuous oxygen therapy if the SpO2 is less than or equal to 88. Or the PaO2 is less than or equal to 60. And that's important to know. So we want to position these patients in semi-Fowler position to help increase oxygenation by allowing adequate lung expansion, provide these patients with small, frequent meals, do some dietary supplements. We want to do meals that consume less energy. So meals that are just easier to eat. So you want to avoid things like celery where they're like crunching and chewing on it forever and getting minimal calories. Hard crackers that are, tough to chew. We want to do meals that are easier for them to eat and use less energy to eat. So patient teaching. So we want to teach them breathing techniques. So that pursed-lipped breathing. So I have directions here. So we're going to sit them upright with their neck and shoulders relaxed. Inhale through the nose slowly, counting 1, 2, and then exhale through pursed lips like they're blowing out a candle, or we say like blowing through a straw. And then they're counting 1, 2, 3, 4. So the exhalation should be twice as long as the inhalation, and we want them to continue that until the shortness of breath is controlled. And we also want them to pace activities. So we don't want to, we have care for our patient. We don't want to do 25 things at once. We want to pace them throughout the day. We want to get them to quit smoking, so smoking cessation programs. We want to teach them about the pneumonia vaccine, coping strategies, adequate sleep, and recognizing signs and symptoms of exacerbation. Cystic fibrosis. So this is an inherited Chronic disease, it's recessive, so the parents may not know that they're carriers. It is required, I believe, in the US for people to be tested for cystic fibrosis. I think it's part of the testing. So manifestations, so there's respiratory issues with this and GI issues. So first off, it's basically a big increase in mucus production, and that starts blocking things. So it's blocking the airway, it's blocking pancreatic ducts. So respiratory wise, we're going to have increased work of breathing, diaphoresis, nasal flaring, pursed-lipped breathing, intercostal muscle retractions. These patients might use their belly or accessory muscles to breathe, persistent cough, that thick, sticky mucus, wheezing. They're going to have decreased exercise capacity and frequent lung infections. And then GI, so steatorrhea, or that like foul-smelling mucousy diarrhea, or stools, I should say. Poor weight gain and growth, so they're likely to be underweight. They could have intestinal blockage leading to severe constipation. This is diagnosed through labs, and the treatment, we're going to do bronchodilators to help relax those bronchioles, the CFTR modulators, mucolytics to help loosen up that mucus. These patients will need pancreatic enzymes because their pancreatic ducts become clogged and blocked. Fat-soluble vitamins to help break everything up, and then daily airway clearance therapy. And that's something that they need to be taught to do at home as well because it needs to be done daily. So if cystic fibrosis is well managed, then the patient and their family have, or the patient and the family have adequate knowledge of the disease management techniques, and they use these airway clearance techniques. It can reduce their chance of getting sick, as well as reducing, exposure and whatnot. There's a lot of community resources for cystic fibrosis. Lung cancer. So this is the second most common cancer for men and women. It's the #1 cancer killer in the United States for both. So typically these patients, they don't have symptoms right away until the disease starts to advance or progress. And when the symptoms do show, it's usually a new cough that doesn't go away, or they have a chronic cough, but it changed. They also may have hemoptysis, shortness of breath, wheezing, hoarse voice, and chest pain. These patients might also present with headache and bone pain. This is bad. A headache is usually brain metastasis, and bone pain is usually bone metastasis. So diagnosis for this, obviously a chest x-ray. You're going to see that tumor or nodule, CAT scan. We could do a sputum sample and bronchoscopy. They will do a biopsy as well to officially diagnose the cancer. Management, so we do radiation, chemotherapy, pain management, and surgery. So for nursing management itself, so these patients are most likely going to eventually need oxygen, so provide that oxygen. Medications as ordered, so if they're getting bronchodilators or pain medications. We want to give them small, frequent meals as supplements. Again, we don't want to use meals that use too much energy and lower their drive. Semi-Fowler's position, like most of them, that's the best position for them, semi to high Fowler's. Teach them breathing techniques, like if they're short of breath, you could teach them the pursed lips breathing. Pacing activities, let's not do 25 things at once, let's pace them throughout the day. If they haven't quit smoking, they need to quit smoking now. And I do want to say one more thing that I want to add to this. Any patient on oxygen therapy, we need to teach them about avoiding open flames. And we also need to teach the family about the importance of them being on the oxygen. Because sometimes family members don't think they need it because they're breathing fine or acting fine, or, we could leave the house without it for a little bit, but that's actually not reality. The oxygen is important and they need to be on it all the time. And palliative care referrals. So these patients definitely need a referral to social work, case management, as well as palliative care. We want to do things that help increase their quality of life. For these patients, positive outcomes can be achieved through around-the-clock pain medications, small frequent meals, oxygen, bronchodilators, and then the palliative care can also help maintain some quality of life while they're fighting the disease. And that concludes the respiratory PowerPoint. I hope you enjoyed the presentation.